Carmel. We're very excited to have you all. My name is Julie Corbett. I'm one of the current interns here at Mount Carmel now, and I'm going to be talking a little bit about intro to our trauma program at Mount Carmel East. This will be a little bit less academic and more about what goes on for our trauma activations and how our trauma program is run. So this should be a little bit more relaxed and laid back topic. So to start off with, our trauma program is now housed at Mount Carmel East. It was originally started at Mount Carmel West, which as of now is no longer in existence. Mount Carmel West, the hospital itself moved all of the patients down to Grove City. However, the trauma program was transitioned to Mount Carmel East prior to the move. Since that transition with trauma at Mount Carmel East, we help take care of patients from a wide area just east of Columbus. So as you can see on this map here, this is where Mount Carmel East is. This is downtown Columbus, and where the majority of the other trauma programs are located in Columbus. There's Grant Hospital and Ohio State, both essentially here in this downtown area, that are both level 1 programs, and Riverside Hospital just a little bit north towards Upper Arlington area is another level 2 trauma program. So we are the only ones that are over here out on the east side. And as you'll see, we'll get patients from Lancaster and Newark. And Lancaster is Fairfield Medical Center, and in Newark is Licking Memorial Hospital. And those two hospitals send us a fair number of trauma patients every month. In addition to receiving patients from other hospitals, a number of our trauma patients actually come through the emergency department first and are then upgraded to either trauma activation or trauma consult. So our Mount Carmel East emergency department is a 50-bed emergency department, and they see, on average, about 290,000 plus patients every year. So just going through a little bit by the numbers, these are some stats that Andrea Light, who is one of our trauma program coordinators and you all meet, she sent to me. Just gross numbers overall comparing Mount Carmel West, where trauma was previously, now to where Mount Carmel East is. Our numbers, just number of patients we're seeing, have significantly increased just every single month we've been there. And then also the down here is just showing what sort of traumas we are seeing at Mount Carmel East. Overall, mostly falls and motor vehicle accidents, and I'm sure that's the same for most of the trauma programs throughout the city. Those spots 3, 4, and 5 are where we really see the change. You'll see motorcycle accidents here in the summer months. Those kind of level off and decrease significantly over the winter months, and then as the weather starts to get nice again, you see them start to pick back up. We also see a fair number of gunshot wounds, assault victims, stabbings, those sorts of injuries as well. So next, just going to go through some activation basics. What happens when a trauma activation goes off overhead, or you see it coming through on your pager? What is your role as an intern? Who else is there? What supplies are available in the trauma bay to you should you need them? So this is just going to be a little bit of a preview, so that way when you are on trauma, you'll know a little bit. And the other unique thing about our program is that even if you do not start out your rotations on trauma, every time we're on call, we are covering for trauma as well. And so you'll have a lot of trauma experience here at Mount Carmel. So this picture here is just looking at the EMS bay at Mount Carmel East. The blue doors over here, the doors to the emergency department for everyone else, all the rest of the patients who come through and are brought by EMS. These red kind of columns here in those parking spots are specifically for our trauma patients, and they have their own separate trauma entrance. So there are 2 separate entrances, whether you're coming in as a trauma or whether you're coming in with EMS just for the regular emergency department. So this is kind of the doorway you see right when they walk in. This hallway here over on the right, there's a picture of it, I think on the next slide. And that is a direct hallway essentially from the trauma bay down to the ORs. So there's a straight shot for us to get there quickly should we need to. And then over here on the left, just right there, is that entrance to the emergency department. So this is that picture of a long hallway. You can't see the end of it because it's filled with construction workers. Right now, Mount Carmel East is under renovation, and so there are a lot of people there working, and I took this during the day one day. So there, you'll just have to trust me that down at the end are the operating rooms. Oops, sorry. So next, this picture is kind of looking at the trauma bays and that entrance. So through those double doors is where the patients are wheeled through. Over here on the right side are the entrances to the trauma bays. There are 2 sets of double doors there. And then over here on the left is the CT scanner. So we have 3 trauma bays at Mount Carmel East. They're just labeled 1, 2, and 3. I'm kind of standing in bay 1 taking this picture. Bays 1 and 2 are set up relatively the same, and bay 3 is a little bit different, and we'll talk about that in a short time. So when you walk into the trauma bay, and this is trauma bay 1, this is what you see when you walk in. There's a lot of stuff in there, which we'll go over, but most importantly, the first thing you should do when you walk in, and I apologize, this picture is rather grainy, there's our lead aprons over here on that left side. Those you need to put on every time you walk in for a trauma. We shoot a lot of chest x-rays and pelvic x-rays in the trauma bay, so it's important you have that lead on to begin with so that you're not scrambling to put it on later when you need to be doing other patient care. In addition to the lead aprons, there's PPE up on this wall that needs to be put on for every trauma. There are blue plastic gowns. You see them most of the time in contact precaution rooms throughout the rest of the hospital. We use them as well for contact precautions in the trauma bay as well. There are blue gloves, and then there are also face masks and face shields in there. In addition, you can kind of see the little red splotch there. Those are red hats. We use those. Whoever is running the trauma should be wearing a red hat, and that kind of signifies to everyone else in the room that they're the person in charge of this trauma and who questions should be directed to, and essentially who is in charge. Because there end up being a lot of people in some of these trauma bays, and that way it kind of helps coordinate care of the patient. So this is a little bit of what you end up looking like. I'm just kidding. This is from the Ebola epidemic. But after you have all your PPE on, then you're ready for the trauma activation to come through. So just going to go through who is all present when a trauma activation is called. So to start with, from our trauma team, we have a senior resident, either a 2 through 4, that are present for all trauma activations. The chiefs do not take trauma call, but sometimes will be there during the day to help out if there are multiple trauma activations or if there's a seriously injured Cat 1 that we know about coming in ahead of time. They will a lot of times come down. In addition, if we have any sort of operative trauma, we should be giving the chief residents a call and letting them know, giving them the opportunity to come in and help out. In addition to the senior resident, there is always an intern present, whether it's during the day and it's the intern on the trauma service or the intern on call that night. You guys will be there as well. And then as of about a month or 2 ago, we have 24/7 coverage of our trauma nurse practitioners. So there is a trauma nurse practitioner there all the time with us. They used to only have weekday coverage, and now we're very lucky, especially as the trauma volumes have picked up, to have their help in taking care of these trauma patients. So usually what happens is there are 2 people at bedside, whether or not it's both of the residents or whether it's one of the nurse practitioners and one of the residents. There are 2 people standing on that left side of the bed over there from our trauma team. The third person is usually at this computer over here putting in orders and writing down information, and we'll go over that in a little bit. Up here at the head of the bed, there isn't always an ED physician who responds to traumas. They stand up at the head and help manage airway if need be, and may also do part of the exam. They have various levels of how much they participate, just depending on the ED doc and also how seriously injured the trauma patient is. In addition, up at the head of the bed is the respiratory therapist. As you can see behind them, or we will see in a few minutes, all of our respiratory equipment is behind them, and so they have easy access to that. Over here on this right side, there are 1 to 2 nurses and an EMT or a tech that is available. They're there to help put in lines, or put in IVs, draw blood, get blood pressures, do vital checks. They're very helpful to have in the trauma bay. And so at least 1 to 2 of them are always there. And then down here in the corner, they're kind of standing off to the side. There is a pharmacist that responds to every trauma activation. We also have 1 to 2 x-ray techs with a portable x-ray machine who are there for the traumas and help us with those chest and pelvic x-rays. For category 1 traumas, there is an OR nurse that comes down just in case we need to open the ED thoracotomy or any other sort of surgical tray down there. They're available to help out because the ED nurses don't do that all the time and aren't exactly sure. So we have an OR nurse there to help us out. And then we previously had an anesthesiologist responding to every category 1 trauma alert. However, we found we weren't really needing them all that often. And so they no longer automatically come down during level 1s, but we do have their phone number for the on-call anesthesiologist in the hospital, and we are able to call them if need be. They also still, every now and then, will come down to traumas just to check things out if they hear something is coming in that may need their help. And then over here at this desk, kind of right in the front there, is our most important nurse. That's the recording nurse. She has all of the paperwork there, and it's actually always set out and ready to go for the next trauma to come in. But they write down what time the patient comes in, all of the patient's vitals, their injuries. They write down some of the EMS report. They're there to just record everything that happens during these traumas. And then over here, usually standing next to them, is where the trauma attending stands. There is always a trauma attending in-house 24/7 at Mount Carmel East, and they will respond to all of the traumas with you to help provide assistance. And then also just kind of back here, just so you're aware, our blanket and fluid warmer is sitting back here because we do use especially warm blankets on pretty much every trauma that comes through. We do take off the clothes of every trauma patient that comes in, so in order to keep them warm, we put blankets on them immediately. So just going to kind of go through now steps to what actually happens when a trauma comes through. So when trauma alert goes off overhead, usually they tell you what category the trauma is coming in, whether it's 1 or 2, and then they'll usually give you an ETA or estimated time of arrival for this patient to come in, and lets you know a little bit how much time you have to get ready for them. When that trauma comes through the door, they're brought in by EMS, and EMS will provide a patient report of any patient information they may have, what happened, what sort of, if it was a car accident or a fall, some of the events surrounding, if they are able to. They'll tend to give you any significant changes that the patient may have gone through while in transport, in any sort of past medical history they may have. It's very important to have on here trust but verify. So our EMS providers are fantastic. But of course, a lot of times they're getting secondhand information and then giving you secondhand information. And sometimes it can end up becoming this big game of telephone, and the information that you receive maybe isn't necessarily all that accurate. So it's important to listen to what they have to say and make sure to evaluate the patient yourself for anything that you see. So once the EMS report is complete, we transfer the patient over from that EMS cot onto our trauma bay bed. And this is where we start our ATLS work. So you'll attend an ATLS course during your orientation prior to starting on July 1. But we'll go over a little bit of ATLS basics here. And then also, so once you've gone through your ATLS, your primary and secondary survey, then this is when you essentially decide, does this patient need further imaging? Do they need to go to the OR right away? Or do they maybe just need to go back to the emergency department and let things kind of calm down before having a tertiary evaluation performed? So, like I said, just a little bit of ATLS basics, mainly because you're going to hear them over and over again. We always talk about the ABCs of trauma. So A is airway. That's the first thing we're looking for when a patient comes through is, can they manage their own airway, or do we need to intubate this patient? Because without an airway, established for the patient, you're not going to be able to really do anything else to save them if they can't breathe. Next is B, is breathing and ventilation. So that's, do they have any rib cages? Do they have a pneumothorax? Do they have good bilateral breath sounds? Those are important things to do. Does this patient need a chest tube before you kind of go on further and complete the rest of your evaluation? And then also circulation and hemorrhage control. So once you've gone through airway and breathing, then you want to make sure this patient isn't bleeding out from anywhere. Do they have any obvious hemorrhagic injuries, and do they have a good pulse? Next, going down after kind of your ABCs, D is disability. So you just make sure that your patient can move all 4 extremities. And this is also where you're going to calculate GCS. And we'll talk about that on the next slide, what goes into a GCS calculation. And then E is exposure. Like I mentioned briefly earlier, the intern at the foot of the bed, one of their jobs when a trauma patient comes in is to make sure that all the clothes are removed. So you should have trauma shears. There are plenty in the trauma bay. You can also order your own. I did. They're a lot nicer, and I think they work much better. But to totally expose the patient, take all their clothes off, because you never know where injuries can be hiding that you're just not going to see if they have clothes on over top of them. And that's also when we're calling for warm blankets. And as soon as we're taking off their clothes, we're covering them right back up to make sure they don't become hypothermic in our trauma bay. So like I mentioned, GCS is the score. So eye, verbal, and motor responses of the patient when they come through. This scale is plastered up on the trauma bay walls in every trauma bay. So it is very helpful. You should know it off the top of your head, but I do use it a lot while I'm in the middle of a trauma, because sometimes it's much easier to look at that wall and go through than it is to try and calculate and remember all of this in your head. So a GCS of 15 is normal. A GCS of 8 or less is essentially a comatose patient, and those are the patients we talk about intubating because there's concern that they're unable to protect their own airway with that low of a GCS. A GCS of 3 is completely unresponsive. So their eyes are closed, they're not talking to you, they're not even making sounds, and they're not moving anything. And then if you see any sort of GCS with a T by it, so whether it's a 3T or a 5T, whatever it may be, that just means the patient is intubated. So especially your verbal response is going to be a 1 most of the time when a patient's intubated. And so that kind of helps clue you in that, okay, their GCS may be low, but they also have this breathing tube in. So what else did we do? Did we give them propofol? And that's why they're not opening their eyes. So that can help provide a little bit of information for you as well. So going through, this is the sheet that we use. The recording nurse, like I mentioned, at their table has their own sheet. This is our sheet that we use for traumas, where we write down all of the information because there can be a lot happening with these traumas all at once, and it's a good way to keep track. And then also you use this to dictate their H&P or consult note from later. So at that top there is the date they're coming in, the time they roll through the door, and the category of evaluation that was called. And just below that are the patient's initial vital signs. So the nurse will record all of that information for you. I usually like to wait until we have kind of run through evaluating the patient, and then once things have calmed down, I'll go back and ask the recording nurse, what time did that patient come through the door and what were their initial vital signs? If you happen to catch them while they're calling them out, that's also helpful too. But a lot of times I go back and just ask them what they have on their sheet. Next is that box, mechanism of injury or chief complaint. So that's what a lot of times you'll get from either the EMS report or the patient themselves if they're awake and talking. And that's just a little bit of what was going on when whatever trauma occurred. So motor vehicle accident at 65 miles an hour, patient was unrestrained, airbags did deploy, positive loss of consciousness. That important trauma information can go in there and help you keep track. There's a little line down at the bottom of that box that's just their tetanus status. We give a lot of life-saving tetanus shots in the trauma bay. And so you can go through there. If the patient has had a tetanus shot in the last 5 years, they don't necessarily need another one. So next is your primary survey. That's that ABCDs E that we talked about. And that's just where you can check off these boxes as whoever is running the trauma is going through. If you're the intern standing there and you're recording this, you want to make sure you kind of check those off as they're doing them. Next down below is a secondary survey. So as soon as we complete the primary survey, most of the time we're moving directly into the secondary survey. And this is going through and just looking for any sort of injuries that this patient could have. And it's going through very systematically, starting from head to toe. Usually the resident or NP at the head of the bed will do about head to abdomen, and then the intern or NP at the foot of the bed will do from hips down and perform that examination. And as you're going through, you're calling out those injuries so that the person who's recording on this sheet and then also the nurse who's recording the information can have it all written down on theirs. And so you can kind of see going through head, are there any obvious injuries? C-spine, do they have a C-collar? Are they tender? And just kind of so on and so forth all the way through. And then also over on this side, the neuro and skin examination as well. There's also this very nice little box of other findings. That's where I like to record a lot of the like lacerations and abrasions that people all call out, just because there isn't a lot of room to write here off of the side. Especially if someone has extensive road rash or something like that. It's nice to just be able to write it all out there. Up here, kind of once we get through the primary and secondary survey, that's when most of the time people ask these history questions. So do they have any allergies, any past medical history, past surgical history, medications, and what's their social history like? And so that's where we can record all of those. And then especially important after the trauma is over, to grab a patient sticker, put that on there. That way it'll help you keep track of what patient this corresponds to. Especially if we have multiple activations going on at a time, or you end up getting multiple activations back to back, that will help save you a lot of headache and frustration if you know what patient this sheet goes to. On the back, and so once we've completed our primary and secondary survey of the patient, this is when we decide what labs and imaging do we need to get on this patient to rule out or evaluate any injuries. So up there on the top is that lab section. There is a trauma order set in the computer that we pretty much use, and that runs through level 1 and 2 labs. So we order level 2 labs essentially on all the patients, and then level 1 labs are all of the level 2 labs and a few extras. So most patients will end up with a CBC, a BMP, PT-INR. They'll also get an alcohol level and a urine drug screen. And then women will end up getting a pregnancy test. Over there on the other side is imaging. Most of our trauma patients will end up with a chest x-ray and a pelvic x-ray in the trauma bay. We will also at times fast. People are doing the fast ultrasound, which we'll talk about in a little bit. And then we tend to get a lot of CTs on patients. So there are some listed there where you can check off of, yes, we ordered that, but there are others you'll have to write in, max face, that is there. So going through and checking those off, especially as patients may complain of back pain or hip pain while we're going through the trauma, I think sometimes it's nice to kind of check those boxes so that you don't forget the patient had pain there and we should probably get a CT scan. Now that next box is interventions. So did you intubate the patient? Did you have to put in a central line? Did they get a chest tube? Did anything else kind of go on? That kind of helps you remember what you did in the trauma bay, because sometimes things aren't very well recorded in the computer, and that way you have it contained within your note at least. That's also where I like to write in if patient gets ANSAF or tetanus shot. I put that kind of in that box as well where there's room. And then the next box over here is consults. So our best friends are sitting up there at the top, the orthopedic surgery team, and then also neurosurgery. They're who we consult most of the time with trauma. And so making sure you're checking off, do we need to consult them? Do they have obvious broken bones? Do we already see them on x-ray? And just giving them a call and letting them know. And then this big box here, the traumatic injuries and plan, especially early on intern year with patients who had multiple trauma injuries. As I was going through that imaging or the lab findings after all of the results had come back, this is where I would write down all of those injuries so that I made sure when I was dictating I didn't forget anything. And so especially patients with multiple injuries, it's helpful to kind of have a nice list there, and that'll help you out when you're actually editing them on the Citrix list, which you'll hear more about here eventually. And then this little section down below, you don't have to sign it. This form is just for you to help you out. It doesn't actually go anywhere. It doesn't get scanned into the patient chart. So it's just for your information. You guys don't have to sign it. So now going through what is contained in the trauma bay and what resources do you have available. So start with, there's just this computer on this side. That's where we put in all of our activation orders. So any patient who comes through, they immediately get activation orders, which are different than hospital admission orders. So those activation orders are just the chest x-ray, the pelvic x-ray, any further CT scans we want in the laboratory workup. And then we can decide later whether or not we need to admit them to the trauma service or to somewhere else in the hospital. Next, you can see up on that TV screen, they had nicely left those up from a previous trauma when I was in there taking these pictures. And so our x-ray technicians are able to shoot the x-ray films and they immediately pop up on that TV screen so that we can see and evaluate them right there in the trauma bay. Down just below it is our ultrasound machine. That's where we do the fast exams. You'll have a in-service and learning time on those the first week or two that you start with us. And we'll go through how to perform a fast exam. There's also, as you can see kind of right below it there, a little printer where you can actually print off ultrasound pictures, and those will actually go in the patient chart. Up there on that screen is where the patient's vitals will be kind of flashing for the nurse who's recording. It's usually turned towards her so she can see what's going on. Just below it there is the blood rapid infuser. The nurses, the ED nurses, most of the time know how to set that up. Sometimes it can be a little bit difficult, but they're working on nurse education to make sure everyone knows how to set up the blood rapid infuser. Next to it is the bronchoscope. If we ever need to bronch any patient, if there's concern that there's something in the airway or we need to see further, that's there. Just below it is a bear hugger. If we have any patients that come in hypothermic, especially in the winter, I know we at least had one elderly woman who had fallen. She was walking out to her car and was out there for a few hours before anyone found her. So she was profoundly hypothermic when she came in. And so we have access to that. And then also the warmed fluid that I mentioned earlier is also there to help us out. And then there are also IV pumps over there in the corner as well. So over here along the back wall, this is where our airway supplies are kept. And then up above it, that GCS scale. So that red cart is the airway cart. This has pretty much every airway tool imaginable you can think of. It has it on there. Mainly it has our different size ET tubes that we use and some other adjunctive airway supplies. Up above it, like I mentioned, is that GCS scale. And that is there so that you can calculate that GCS. You don't have to do it from memory while running the trauma. Next to the airway cart is a ventilator. There's always one in the trauma bay, so we don't have to sit around and wait for them to bring us a ventilator. And then also next to the ventilator is the glide scope. And so that way you can see what you're doing when you're trying to intubate a patient. I believe we also have Mack and Miller blades in that airway cart, but the bronchoscope is nice and allows you to see. It makes intubation a little bit more streamlined. So next, this is just at the head of the bed. There's a boom there, and I just wanted to point out a few things on it. One, it has suction on it, so if you need to suction out someone's airway, that is available. We also have an otoscope and ophthalmoscope. We use them on all the patients to look in their eyes and ears when they come through as a trauma. There are, like I said, trauma shears. This is usually where they're hanging if you need them to help take off patients' clothes when they come in. So over here on this wall on the right side are 3 carts down below and the 3 cabinets up above, and those have even more supplies available to us. So we'll go through those just pretty quickly here. So that first cart is an IV and wound cart. It has some suture in it, has some lac repair kits. So those top 2 trays are all of the IV and blood draw supplies the nurses need to do that in the trauma bay. That next middle cart is the thoracotomy cart. You can see the OR tray sitting down there at the bottom, and the rest of it are some other thoracotomy supplies and kind of other miscellaneous supplies. But mainly it's there to house our thoracotomy supplies. And then over on the end is the chest tube cart. So it has the Pleurovac suction canisters in there. It also has chest tube sitting over there on the side, and then the actual chest tube insertion kits are housed in that cart as well. So it has everything you need to put in a chest tube emergently in the trauma bay. So starting up above, this is that very far left cabinet. That top row are Foley supplies, so they're actual Foley catheters as a straight cath kit, and then there are also just those plastic urinals. On that middle shelf are the cervical collars. The ones on the left side, those look nice and squishy, are the Aspen collars. They're more comfortable, but also more expensive. So we try to save those for patients that we think may actually be in the cervical collar a little bit longer. There are also field collars over there on the right side. Those are kind of the flimsy ones that you see most of the EMS providers have. They're much cheaper. And so we like to use those on most patients when they're coming through. Just because we do end up removing a large majority of the cervical collars we do put on patients. We found that we're ending up wasting a lot of money putting Aspen collars on everyone. And then on that bottom shelf are blood pressure cuffs and Doppler supplies. So there is a manual blood pressure cuff. There's a stethoscope that's essentially a one-time use stethoscope. That the Doppler ultrasound is sitting right there, or the handheld Doppler is sitting right there. And then these are the blood pressure cuffs that actually get plugged into the automatic presser. So all of that is there and on that bottom shelf. I find myself asking for the Doppler often in traumas just to make sure we have good pulses on people. So this middle shelf. Up on top is the Belmont tubing for the rapid infuser. The nurses should know where that is, but just so that you are aware of where it is if they're ever looking for it and you're needing it in trauma. That middle shelf, there's a pericardiocentesis tray and also a thoracotomy kit as well in there. And then down in the bottom, there are central lines. So there's the introducers are down there, and then there's also the internal defib paddles are on the right side in case you do an ED thoracotomy and need those. I do appreciate when you get to meet me. I am rather small in stature and had to ask. Dr. Dazan previously had the central lines up on the top shelf, and I found all too often I was doing some weird jumping action trying to get those down. So they very nicely move those down on the bottom shelf where those of us who are vertically challenged can reach them. And then over on this right side, this cabinet is mainly a lot of ortho supplies. There's a traction bow set. There are some lac repair kits up there. And then also our IO drill is on that middle shelf if needed. The bottom shelf contains pelvic binder and some tourniquets. And some other random supplies, some pressure bags and tubing, IV tubing. So just to point out, over in Bay 2 is actually where our code cart is housed. We just don't have enough room in Trauma Bay 1 for it to be sitting in there all the time too. So it's sitting over there in Bay 2. But usually if there's a patient who's coming in who's already in cardiac arrest or we're concerned about it, the pharmacist usually will go ahead and grab that cart, or one of the nurses will, and bring it over into Trauma Bay 1 so that we have it there. And so this is going to go through just really quickly Trauma Bay 3, the differences, because 1 and 2 are pretty much set up exactly the same. Bay 3 is where things get a little bit different because we do use it for OB traumas and also OB alerts. So if there's an OB patient in the emergency department and they need urgent or emergent care, especially related to the fetus, then a lot of times they'll bring them into the Trauma Bay. So that this is where all of those supplies are housed. That blue cart right there, in the back is the PEDS crash cart, as you can see, kind of compared to the blue crash cart there just in the left corner of your screen. It has all of those pretty colors for all the pediatric stuff in it. Easiest way to tell the difference. In the middle there is an incubator, just in case anyone does deliver in the trauma bay, we have that available. And then on the end is the PEDS airway cart. Over in the corner, there is a fetal monitor. So if we have any sort of pregnant patient, especially after motor vehicle collisions, most often I believe when we see them, they will call an OB trauma alert. And that means there will also be an OB physician, and quite a few OB nurses will come down after we finish our primary survey. Usually we let them get in there and start working on fetal monitoring while we're completing our secondary survey. And then in addition to the other 3 kind of carts that are already there, there is an OB cart. It contains all of the OB supplies. I don't actually really know what's in there. It's just kind of labeled for them. And then along this back wall of the trauma bay is pharmacy territory. It's where emergency release blood is contained. We also have lots of medications in the Pyxis, common ones we use in traumas. There's rapid sequence intubation medication. There are medications for codes. There's also our life-saving NSAID and tetanus back there, so things that are easily accessible for the pharmacist should we need them. They also have access to the ED pharmacy should we need it, but we try and kind of use what's easily and quickly accessible there. And then across the hall, this is the nice little CT-looking cave. That's where our CT scanner is. Whenever a trauma alert goes off, they clear out that CT scanner, and so that it's there and available and ready for us pretty much as soon as we're ready for them. So it's very, very nice to have that as soon as we're done evaluating the patient, we decide they're ready for imaging, we just kind of roll them right across the hall and they're ready for us. And so what do you do after you've evaluated your trauma patient, you've ordered the labs you want, you've ordered the imaging you want? After they get the imaging or lab work done, they get taken to a regular emergency department room where they can kind of sit and hang out and wait for those results to come back. And then that way they're also not taking up a trauma bay room just in case more traumas were to come in. We like to get patients kind of out of there as quickly and safely as we can, and that way we have that room ready for the next trauma to come in. So after all of that happens, you want to make sure you regroup with your team, with your senior resident, and also with your trauma nurse practitioner. Make sure kind of everyone has a job, or at least you know who is doing what. You'll hear this a lot with us, but make sure that every patient is molded. So we talk about MOLD, MedRec orders, list, and dictate. So that's kind of going along with the assigned tasks. Make sure you know who's dictating this patient's HMP. Make sure at least someone has put them on the list by now. And then you can decide, do we need to admit them? Do we need to put in orders and do their MedRec? Additionally, you want to make sure you're following up the imaging and lab work. It can be easy at times to forget about these patients because they sit down in the ED and then you go back and are called to the floor and are taking care of surgery patients. You need to make sure to not forget about your trauma patients. You want to follow up on their imaging and their lab work that comes back. And then you also need to call any consulting services that are needed. So do they have any orthopedic or neurosurgery injuries that you need to give them a call and let them know about? And then every patient who comes through, you pretty much have 3 decisions to make. You either decide to admit them. Do we want to admit them? Usually to medicine is kind of the only other service we admit patients to, and trauma will stay on as a consult. We don't do that very often, but sometimes patients come in as maybe a trauma, and actually it turns out they have more medical issues and less traumatic issues, so sometimes we'll admit them to medicine. Or can this patient go home? Do they either not have any injuries, or do they not have any injuries that require a stay in the hospital? So those are pretty much your 3 options you have when a patient comes in as a trauma. And then over here on that right side is what we call our yellow cards. So these are for the attendings. A lot of times they'll fill them out themselves, but we also fill them out for them a fair amount as well. So making sure you got a patient sticker, date and time. This is kind of how they do some of their billing for trauma. So going through the mechanism of injury, what injuries they did have, just kind of filling out. It's very quick, it's very easy, and it helps them out a lot to do that. So I think that's my last slide. Hopefully this was relatively painless. We look forward to having you out at Mount Carmel and are very excited for you to join our program, and hopefully you feel a little bit more comfortable coming in and starting with some trauma activations after going through this lecture.